Hello and welcome to our program. I'm Dr. Lewis Hassel from the University of Oklahoma Health Sciences Center. And our program is the digital slide review and sign out portion of the Digital Anatomic Pathology Academy. And we're happy to share cases that are included in the teaching materials from that site, which is a joint venture between Path Presenter, well known in many respects, and the Digital Pathology Association, eager to help the pathologists of the next generation become better trained and better prepared to handle the challenges that are ahead. So our case today is a GI pathology case. The woman is an East Asian immigrant, arrived a few years back, who has, over the course of quite a long period of time, had intermittent jaundice, some occasional abdominal pain and nausea of uncertain etiology. Scanning led to the discovery that she had a pattern that appeared to be somewhat cirrhotic, with some accentuation of some of her bile ducts. She had some gallstones as well, and she was found to be developing liver failure. So with that diagnosis and sort of a secondary pattern of biliary cirrhosis, it's useful to consider sort of what the etiologies of bile duct-based disease are and some of the different patterns that can be seen. So note that with primary cholangitis or primary sclerosing or cirrhotic pattern, you get a destructive process that involves the small and intermediate ducts that is presumed to be a T-cell mediated autoimmune process. And so on biopsies, you'll have the bile duct dropout pattern where the proportion of portal triads with few or no biliary ducts just increases exponentially. And this is a disorder most frequently seen in middle-aged women, such as our incident patient here. A secondary pattern of biliary cirrhosis, however, is thought due to obstruction of large bile ducts with potentially either ascending cholangitis or intermittent obstruction leading to that pattern. So in our patient, the liver failure was severe enough that the patient actually came to transplant. And at transplant, there were a number of unusual features that were disclosed. As you can see here, there is a pattern of cirrhosis, fibrosis around these larger biliary ducts, and some nodularity to the hepatic parenchyma with, as you can see here in this portion, areas of active inflammation. In addition, you can see that the central veins are open. The pattern of inflammation seems to be leading to a significant proliferation of these small biliary ducts, as you can see here. Now, also of note, however, is the presence in some of these larger ducts and around some of these larger ducts, as you see here, of a vaguely granulomatous process with destruction or damage to the epithelium here, some level of regeneration and variability to these cells, although no frank dysplasia per se, and this intraluminal sort of exudative process of fibrin, debris, and so forth. And secondary to that, the surrounding fibroplasia that you see here, fibrosis accompanying this inflammatory process. Here we see another bile duct, branch duct, also dilated and perhaps indicative of some degree of obstructive symptoms further and elsewhere. Looking around this lesion a little bit further, we see other areas where, again, we've got this fibroplasia and inflammatory response infecting and involving the liver cell plates. Now, in addition, here in this larger duct, however, we begin to see a little bit more exudative process. And if your eyes are sharp, you've already identified that we have a couple of somewhat hardened or slightly refractile structures right there, another here, and you may be beginning to wonder if this is a parasitic infection or some foreign body of some sort involving this liver. We can see here again this area of more sort of fibroblastic proliferation surrounding this. And here a degree of a little bit more epithelial atypia accompanying this, along with these areas that show a significant eosinophilic component to the inflammatory process, perhaps underscoring the nature of the changes that we're seeing secondary to these eggs that you can make out here in greater numbers. So this, of course, raises the question of a parasitic infection, and in the liver and the bile ducts, we're going to be thinking about various flukes or possibly schistosomes as well. But as you probably detected at lower magnification, we have the culprit right here. And as we look here, we can see that this indeed is the gravid uterus that is putting out all of those eggs. And we have a sort of folded fluke-like organism with areas of, integument, some digestive structures here, and of course the gravid uterus. Note, however, the response that we're seeing around this in the bile duct. Now, this is not yet sort of ulcerated here in this area per se, but notice that we have this really pronounced, almost adenomatous type of proliferation in the bile duct, periductal glandular structures, which is beyond what we would normally see in this situation. We'll also note here, here's another view of that same fluke in this structure with, again, this nice pattern of adenomatous hyperplasia surrounding the tissue. Now, there's one other feature I wanted to identify here, and that is that sometimes we can get these granulomatous responses here without, well, there's more eggs there in that one. But sometimes we get this sort of an eruptive granulomatous process out in the parenchyma that can be devoid of eggs or identifiable structures. So if we look over here, for example, here we see this very eruptive granulomatous process without significant evidence of eggs, and at least that I can see in this particular area here. So given the size of the organism, patient's Asian origin, we can presume that this is the liver fluke, and that is most commonly Clonorchis sinensis, part of the Opus thoracus genome or genotype. And interesting study looking back many years ago denoted the response to this infestation. I don't know if this was done from experimental work, but quite a nice study, perhaps based on animal work, that on first infection, there is a sort of desquamative process of the epithelial cells, which is then followed by some degree of hyperplasia in that epithelium, responding to this to try to compensate. And then that ultimately leads to this more adenomatous tissue formation around the lesion, around the organism. And then finally, we get the more pronounced inflammatory process with various abortive acini and fibrosis in the wall of the bile duct. And it's this fourth phase where you're likely to develop potentially neoplastic complications and so forth, more scarring and stone formation if the organism has invaded the common cystic duct or the gallbladder, and intermittent obstruction is also noted in these patients. So geographically, this is primarily localized in East Asia, And here we can see sort of the prevalence and high frequency zones. But notice that, many of our East Asian and Southeast Asian rivers have origins here in Central Asia, Central China, that is very close by each other. And so our high-risk areas would be southern China, portions of northern Vietnam, and areas of Korea, but other broad areas of China also can be quite heavily infected, as can even areas of Mongolia and far west eastern Russia. And of course, as you see here, there are the Clonorchis sinensis is the most frequently encountered one, but other species of the Opisthochus can be found in other locations as well. In terms of life cycle and so forth, I'm sure that many of you have learned this, but the human is a definitive host in this situation and can therefore be the origin of the eggs. Now, other animals, fish-eating animals in particular, can also be definitive hosts and propagate the eggs. But typically, once the egg is, in the free water, this is where the water snails ingest the eggs, and within the snail, the eggs develop into Myristidia, Sporocysts, Rediae, and ultimately free-swimming Cercariae, which then pass to the intermediate host of the freshwater fish. Within the fish, they encyst into a sort of metacercaria in the flesh of the fish, the skeletal muscle, and then that is in turn ingested by the human. Excistation occurs in the duodenum, and migration into whatever nearest bile secreting source is the next consequence. And the reason they localize into the bile ducts is because these organisms thrive on the biliary salts and fats and other substances that are found in rich abundance in the bile. And in terms, I'm sure you saw from that cross-section of the uterus, these flukes can produce a lot of organisms. They are androgynous. They don't need a companion. They have a spermatocyst and an egg forming unit. So these eggs that are formed are fertile without the need for a sexual component. And in terms of diagnosis and treatment, well, it's important to recognize that many infestations are totally asymptomatic. Early symptoms may be a minor fever or cold, sort of fever, malaise kind of symptoms, but they can be very, very mild. And of course, in terms of diagnosis, once we start to suspect it, stool examination looking for parasitic eggs is the most frequently available or most widely available test. But there are other tests available, and ELISA test as well as PCR methods can also be used to make the diagnosis if we don't have the visual tools to do this. And in general, egg numbers and DNA number quantitation, of course, would correlate with fluke burden. And in some patients, the number of estimated flukes can really be quite remarkable, in the thousands of flukes. But quite frankly, demographic background and dietary habits, consumption of raw or poorly cooked fish, really are the things that either should prompt regular screening or, in many circumstances, just prophylactic intermittent treatment to sort of clear those flukes and their byproducts. So with that, our final diagnosis in this particular case was secondary biliary cirrhosis due to Clonorchis sinensis. And we hope that that was an instructive case for you, and certainly not something we see every day in our laboratory, and I imagine not in yours as well. If you like this, please give us a like. And of course, we hope you'll subscribe to the channel so you'll catch future releases. If you have questions or comments, want to add additional information, please don't hesitate to comment in the comments below, or contact me directly either at my email or on Twitter. So until next time, thanks so much for joining me.